How many people here are not physiotherapists? How many are doctors? Okay, good, because I might badmouth a few doctors. But the work that I'm going to present to you is really been done over many years with many different people collaborating. Some of the people that you've heard are David Creighton, so the Creighton model we'll talk about, and Arnlug, who won the award yesterday, and then a whole bunch of other people. So how will this talk affect your practice? I hope it will, maybe not. But I hope it'll help frame the understanding of what return to play objectives are and provide you with a framework to work through the maze of all the factors that we've talked about over the last day or so. And then I want to get people to think about the capacity, who has the capacity to make the return to play decision? And is it one person, or do we need a better model? Currently, we're stuck in a legal framework. I mean, the judges get to decide, and usually they sort of say the doctor has to decide in most countries, but in different countries it's different. And so we'll get to that. I don't speak German. Here's my attempt. Wenn Sie irgendwelche Fragen haben, bitte stellen Sie auf Deutsch. And if you have any questions that you'd like me to answer, demandez en français or English. Thank you. So, the return to play objective, really, we've heard all about re-injury. But I'd like to suggest to you that we should be thinking about the best interests of the patient. And that's really what you mean when you say re-injury. But re-injury is only one factor of the interests of a patient. We don't treat injuries, we treat people. And I want to talk about shared decision-making. That's come around. In some cultures, in Canada, it's a big thing. We'll talk about what that really means. And when we first wrote this, had this idea with this model, and we sent it to Nick Notati, who's an orthopedic surgeon. He wrote, "Let me tell you about this story that I heard last week. An 18-year-old female member of the national soccer team had ACL surgery 6 months earlier. The athletic therapist cleared the athlete for training. There's an important competition. Coach wants the athlete to play. The athlete wants to play. The therapist says the athlete can play. And then the surgeon says the weekend before, sorry, you can't." That's real life, where we see the same information, and we come to different decisions. And when it's done in isolation, this creates conflict in the athlete's mind, lack of trust. That's not good. What I'd like to do is create a model, 20-year goal, create a model where we decrease the chance that this will occur. So now I'm going to try something that I've done in other classes. In workshops, it's easier with 30 people or so. But I'd like everybody to touch touch the shoulder of the person in front of you. Right? Okay? And behind you. To the left, to the right. Okay. You're now groups of 5 people or so. Okay? I want those 5 people, within reason, obviously there's overlap, I just want you to take the next 30 to 60 seconds right now and talk amongst yourselves, what are the best interests of the patient? Go. For those who aren't talking, I have eyes, so those are the people I'm going to ask. Okay, so we could let this go on for probably an hour and people would have some interesting and heated discussions. What were, say, somebody from the back of the room, one speaker from the back of the room, what was one of the interests that you came up with? Anybody? Any of the groups? Nobody in the back talked. I couldn't see well enough. Okay, somebody in the front. Anybody? I forgot to tell you to elect a spokesperson. Long-term welfare. What does welfare mean? Overall well-being. Okay. Anything else? Short-term. Best performance. So being able to actually compete. Confidence. Okay. Now I also want you to think about, if you're bored of listening to me, when people talk about shared decision making, as a healthcare professional, I'm talking to the patient. I view my role as providing information and helping the patient come to a decision. But in shared decision making, it implies that there's equal power that's shared. Maybe not equal, but there's some sharing. What do you do in that shared decision making when there's a disagreement and you don't come to the same agreement? You don't have the same decision. Is it really shared? So when we're talking to the athlete, when we're with the team, we say, no, you can't. You share, we're going to talk, and we're trying to convince them. But if we can't, we go, no, he can't play. Or in some cases, as we heard earlier from Eric, sometimes the athlete just goes and plays. There's no shared. The athlete is deciding. And so what does shared decision-making really mean? So we're going to review now. This was, David Creighton was an undergrad student at Stanford, and I was helping them out with some research, and we had this idea. People were saying it's so difficult to work through, and this whole framework, first of all, this is an updated model. Most important thing is that I came up with, actually my wife came up with this acronym, and if you have an acronym, people will follow it much more easily than if you don't. So strategic assessment of risk and risk tolerance. And when I've presented this over the last few years, a lot of clinicians had difficulty there. What about this factor? What about that factor? And how does this? So I've remodeled this, and where's my, I will use this as my prop. One of the things that you've heard is how this factor or that factor or this test is a good predictor of injury. And implicit in that is the assumption is that the test by itself means something, and it doesn't. No test means anything in terms of re-injury risk by itself. This is in statistics, we call it a bivariate problem. There are two factors. This piece of this napkin, nothing's happening, it won't tear until I put too much stress on it. So every injury occurs when you put more stress on the tissue than it can absorb. And these medical and sport risk modifiers really refer to tissue health. The first step is, how strong is this napkin compared to this pen? But that doesn't tell you which is more likely to get injured unless I tell you what stress I'm putting on it. So if somebody is playing American football or real football, we don't know if, I mean, we can use these tests, but their risk of re-injury, that health of the tissue, is not important unless we know the stress. Because if they're playing ping pong, then the tests that will predict injury are going to be completely different than the tests if they're playing footballs. And so the second part, the sport risk, is really about the stress that you're going to apply, the magnitude of the stress, the type of the stress. And these factors don't matter, these names. In any activity or any sport or any athlete, you can change these around. And some of them will apply in more than one category. But it's the concept that you have the health of the tissue and the stress that you're applying to it. And those two give you your risk estimation. And what you've heard about over this yesterday and this morning is about the risk of re-injury. But the best interests of the patient might also be long-term. Somebody said arthritis, overall well-being. In some cases, it's death. This model is one outcome specific. You have to apply the model for each outcome you're thinking about, and then you combine them across, and we'll talk about how you do that later. And this model is nothing that we came up with. It's a standard Bayesian decision theoretic model that I happen to work with. A statistician is a Bayesian, and so we talk and we go for lunch. And so I've known about this for years, and when everyone gets going, all I did was take this model and apply it to sport. And you can take this model and apply it to any decision-making process that you have to make. There's no rocket science here. Let's use an illustrative example. So we have an NCAA full scholarship American football. Those of you who don't know, this is a defense, linebacker that tackles at very high speed, and it's early in the regular season. And so we sent this out to clinicians at the American College of Sport Medicine with an AC sprain. This is 3 weeks old, no swelling, no step deformity, a little tenderness and pain at the end of horizontal adduction. How many people would send this person back to play? Raise your hand. 1? 2? 3? How many people would not? How many people are chicken to raise their hand? So there's no right or wrong. What we had in the American College of Sport Medicine physicians is we actually gave them 6 examples. So that was example number 1 over here. But then we increased the severity of the injury. 3-step, they can't move it more than 90 degrees. And in that first example, about 70% said they would return, and then 30% said they wouldn't. And as the severity increases, it changes. Now, the sport risk modifiers, where we're going to talk about the stress that you're applying to the tissue. And to explain to you why these are important, we're going to change this linebacker to a field goal kicker. For those of you who don't know about American football, the field goal kicker comes on maybe 2 or 3 times during a game, and nobody's allowed to touch the field goal kicker. If they touch him, they get a huge penalty, okay? And it's just really bad. So the field goal kicker comes, he kicks the ball, and he walks off the field. Early in the regular season, how many people are going to let this field goal kicker go back? Good, people got their hands. That's great. Okay, and in the American College of Sport Medicine, clinicians, which were physicians and therapists and trainers, again, almost 100% in the first one, but as you get more severe, not everybody, maybe 30% said they would go back even with the most severe, so much bigger. So that's all this is that you can't assess risk of re-injury without understanding the activity level that somebody's doing. Now, what are the reasons for the differences? Why did some people say yes and some people say no? There's only 2 possible reasons. One is we actually estimate the risk differently. I gave you a clinical vignette. I did not tell you what the risk was. So somebody might say it's 20% and somebody might say it's 50%. I don't know. How good are you at actually assessing risk? So this is a study that we were hoping to get 100 patients. We only got 10. Arnlog was, who won the award, was part of this. So we're just writing this up now. But this is just risk estimates. So when the patient was ready to go back, we asked the athlete and the treating physio and a sport medicine physician, all looking at the same, or had access to the same information. I don't know what they actually looked at. What they thought the risk was. And here the physician thought the risk was about 10% with a range from like 5 to 15, and the physiotherapist thought it was about 20 with a range from 15 to 30, and the athlete thought it was about 25 with a range of 20 to 30. Different risk estimates. If we can't agree on what the risk is, then of course we're going to come to different decisions. Now, we don't know which is the right one. Here's another example, another athlete. Here we see the athlete is down at 10%, the physician is up at 30, and the physiotherapist is up at 40. Very different risk estimates, and they're going to lead to differences of opinion and judgment. What about different risk tolerance? So there are people who will go hang gliding and people who won't golf, right? Those are very different types of people. This is a completely different study where we use clinical vignettes to look at medical decision-making. And basically, this just tells you, I don't want to go into all the details, but tells you that this treatment for rheumatoid arthritis had a 20% benefit. And these horizontal bars are the estimate that each individual person, these are individual people, gave. So this person thinks it's about 20%, 20%. And if we look, all of these people here had the exact same estimate, and these are their uncertainty, and the same uncertainty. But red is yes. We had 2 people who said, or 3 people who said that they would say yes, they would recommend treatment, and the others said no. So you can have differences because of different estimates of re-injury, or whatever you're thinking about, and also because you have different values, even if you have the same estimates. And there's nothing wrong with that. We're people, and we're allowed to have different values. That's what makes the world interesting. So different people have different values. Maybe some people think short-term are more important than long-term. But then I want you to think about what factors affect your tolerance. So within a person, there are particular contexts where we are more tolerant or less tolerant. And that's what the third part of this was. The modifiers of your risk tolerance. So now, we're going to talk about this athlete, and it's the linebacker again that's running at high speed, and only a few of you said. So again, how many people in the first, now that you're not scared anymore, how many people in the first case would let the person go back? It was the linebacker playing, only a few. Okay. Normally, it's actually like 50%. You guys are very conservative. So maybe you just don't know football. So now, it's $1 million signing bonus. That's what's at risk if this person doesn't go back. Same injury. How many people are going to let the athlete go back now? Right? There's nothing rocket science. Now, for those who didn't raise your hand, if you were the athlete, would you go back? Raise your hand or not? Yes, of course. So this isn't rocket science. And if you look at the literature over the 60s and 70s, it's like, no, only the health of the athlete. That's the only thing. Injury risk, that's it. It's nonsense. I mean, that's not the way we are as human beings. We weigh the risks and benefits in life all the time. And it's the well-being of the athlete. The athlete's poor. $1 million goes a long way to athlete well-being. So when we had this decision modifier, we see an up. So not everybody says that they would go with $1 million, but we went from 70% up to 80%. And you can see that when it's really severe, very few people change their mind. When it's moderate, and it depends what those risk estimates would be. Now, in the real world, we have multiple outcomes. So that was just generally, would you send them back? The model I told you was only one outcome at a time. So we can talk about our risk assessment might be for re-injury under 10%, pain 50 to 70. And, maybe that's me. Work disability, 20 to 30%, they're not going to be able to work. Maybe it's not a pro athlete, it's just somebody who's trying to go back to play recreational football. You're going to miss work, 20, 30% chance that you're going to miss a week of work or 2 weeks of work. That's just not acceptable to go out and just play in a game. Why don't we wait? But that's my value. Why, as a medical doctor, are my values about work disability any more important than the athletes? I haven't figured that part out. So perhaps some of you think that that's acceptable. And if it is, then if you have anything not acceptable, then you can't go back. But now we've changed that to acceptable, so now you can return to play. But those are only the short term. What about the long term? We have osteoarthritis, disability, cost prohibitive. Well, for me, those are all acceptable. Okay, what if we change that to 10%? How many people think that it's acceptable to send somebody back if they have a 10% increased risk of osteoarthritis. So most people. 20%, 40%. I go higher and higher and higher. At some point, there's going to be some of you who think that's acceptable and some of you who don't. Why is your opinion as the clinician making that decision more valuable than the next opinion, the second opinion, or the third opinion, or the athlete's opinion, or the coach? And we saw about the pressure from the coach and the team. Those are real too. They have their own judgments. Remember, what we're trying to think about here is the best interests of the patient, not the best interests of the club. So we do want the best interests of the patient. So now, who has the capacity? Basically, the risk estimations. We don't know who's good at it or not. So in this case, in this study, what we did was we surveyed, in Canada, medical doctors, physiotherapists, athletic therapists, coaches, athletes, and sport organizations. And we asked them, who do you think has the best ability to estimate re-injury risk? This is fascinating. The doctors said the doctors. The physios said the physios. The coaches, well, they split, and the athletes split, and you guys will be happy because the athletes thought the physios were better than the doctors. What about long-term problems? Well, the doctor said the doctors, the physios, some of them moved over to the doctors. Coaches and athletes both thought mostly doctors, although the athletes still thought the physios were good. What about psychological impact? Because it's the whole person. You think about training for the Olympics 10 years, and then all of a sudden you're told you're not allowed to compete. A lot of athletes would go into minor depression, certainly become sad, mood disturbances. But it's an identity, and to take away that identity from a person has or may have huge impact on the athlete's well-being, on their best interests. It's not just about re-injury. So, psychological impact, hey, the doctors moved away, good. So they said the athletes. The physios circle, the coaches think that the coaches are the best, and the athletes think the athletes are the best. What about financial impact? Yeah, good. Yes. Finally. Okay, athletes think the medical doctors. Now, I actually would have said coaches myself. I don't know how an athlete actually understands the financial impact that much, given that they're injured and what happens if they go back or not. They don't have any experience with lots of athletes, but the coaches do. So I would have gone with the coaches, physiotherapists, athletes. So I'm going to come back to who is best at estimating these risks. So we can look at each of those outcomes separately, and some of them are more difficult than others. I want to, over the next couple of years, and if you guys are interested in knowing how good you are at estimating risk, if any of you have access to a large number of athletes and want to participate in a study and collaborate, please send me an email, ian.schreier@mcgill.ca. And we can reproduce this type of study, even if you, as an individual clinician, you can just, eliciting risk is a little bit difficult, but we have this questionnaire, and once you get the hang of it, it's easy. So you can do this with your athlete, and you do it yourself. You send me the data. We get 800 people doing this. We'll be able to actually answer how good we are at estimating risk. Because right now, we just talk to the top. Oh, you have 20%. Oh, you shouldn't go back. Well, you shouldn't go back because it's 50% that you're going to get hurt over the next week. We don't know that. The other thing I'd like to say is people talk about, just because I've heard over the last day and a bit, how past injury is the greatest risk factor for future injury. And that is true, but that does not mean it's causative, and it does not mean that you're doing a bad job. So the analyses in all of those papers that were cited are completely flawed. They do not tell you that you have not done a good job in rehab. Even if you returned the athlete back to their baseline risk, those analyses would have had the same results. So we published this in a paper, Gavin Hamilton, 2011, in American Journal of Epidemiology, if you want to read it, about how you have to assess re-injury risk and if you've returned to baseline. So, informed consent. The individual is not able, if you're going to have the athlete be able to give a risk, the individual is not able to evaluate risks and benefits when they're injured. Informed consent, The individual must have adequate reasoning faculties and be in possession of all relevant facts. Impairments to reasoning include emotional immaturity, high levels of stress, intoxication. I think we'd agree that a lot of athletes are immature. So are doctors, so are physios. Stress in competition. You can argue that we don't have the capacity during that heated game to actually make that decision, because you don't have the cognitive process and time to actually work through things. And then the part about the athlete, the problem is that they're susceptible to intimidation, the coercion from the coach. But so are therapists, and so are doctors. And the question is, can we come up with a model that can reduce that intimidation? And that's where I'd like to go over the next 10 to 20 years. Take-home messages. The best interests of the patient are based on value judgments. There's no right and wrong. The required knowledge is about risk assessment and weighing those risk tolerance modifiers. The capacity to make a decision, there's no one profession that has all the knowledge, so we always have to share knowledge. And then at one point, when does an autonomous individual who can decide to go hang gliding or urban jumping and take all those other risks, but their ankle hurts a bit and we're not letting them return to play? So when do they get to choose? And the team approach versus empowering an athlete, intimidation. So everything I've said to you, if we can get sound on this, everything I've said to you is my own interpretation. And that's a little bit loud. And we come to everything we do with our own biases. And certainly everything I've told you here is my own bias. And I'd like you to just recognize that so we come to it with our own biases. Please remember that every time you're treating a patient or you're coming to a decision. And everybody's been showing how their team is the best, so I decided I'd show out the Canadian hockey team. And I've been amazed if you've looked at all these sports. I don't think I saw any of the women teams. So this is our Canadian women's football team winning the bronze medal. And again, I am not going to torture you with my German. Thank you very much. Oh, there we go. Thank you.